Bob, you showed up just in time. I was going to tell everybody you were afraid to come debate, which is the last statement I'm going to make that I'm going to win today. So those of you who have heard me debate before know that I am always given the one in which I'm going to get skewered. And this one is no exception. So you guys saw, where's my, those are the same disclosures I had before. Nothing's changed in the last few minutes. And this is a variation on the last slide. So this slide shows up, this picture shows up in most of my debate talks because, well, it's obvious. So what I thought I would do is present a case. I was going to actually introduce it by saying this was a case that came to me from Dr. Baldessano. It's not quite true, although much of this case is quite related to a patient that I saw from him. A 13-year-old boy who presented in March of 2001 with short stature, having dropped from the 50th to the 10th percentile. He was referred to us from the pediatric endocrinology department after he'd had negative growth hormone testing for short stature. He was having mild cramps, loose non-bloody stools, had a sed rate, a mildly elevated CRP, an albumin that was low. All you guys recognize this patient. He's worked up. He's got mild granulomatous inflammation that was identified in the TI and in the cecum, and had some scattering of small bowel apathy on a video capsule. He got Dr. Baldessano's regimen of enteral feeding, supplying 85% of his RDA, which he did for the first 3 months of treatment, and his minimal symptoms subsided. He then chose that, or his parents, I should say, chose for him that approach on a PRN basis when he started to demonstrate symptoms of cramps or loose stools. And he did pretty well. He was asymptomatic. His weight gain improved, and he actually grew. Bob will tell you that's what we should expect from that kind of treatment. 2 years later, he's now 15 years old. He's asymptomatic, 50th percentile for height, so he's done quite a good job of growing. He's now Tanner 4. His family has adopted a gluten-free, dairy-free diet for him, which he claims to take even when he's at school. And he resumes NG feeds episodically for symptoms of pain or diarrhea. His labs are all fine except his calprotectin, which turns out to be quite elevated. And so that got him another video capsule, and he had scattered aphthous ulcerations throughout the small bowel. I can't remember if he had a colonoscopy at that time. There was nothing to suggest that he had colonic disease. So he had primarily small bowel Crohn's disease at this time. He's asymptomatic, except he's got a lab test that's abnormal. And so we sat down with the family and we discussed what the therapeutic options were, including 5-ASA, for which I personally feel that there's no particular benefit. We suggested that antibiotics might make some difference in him, but the mother was particularly afraid of that because her father had been hospitalized with C. diff a number of months before and had been in and out of the hospital a number of times because of the C. diff, so antibiotics were a non-starter. As it turned out, so were immunomodulators and biologics because the parents were worried about cancer. So, not surprisingly, the parents and the patient were not interested in issues related to mucosal healing. They didn't want to hear anything about it. They didn't want to look at pictures. They weren't interested in the role that any of these treatments might play in decreasing risk of future complications. And so you all can predict what they chose to do, which was absolutely nothing. And that's the problem. So the title of our talk is focusing on the endpoints that matter, and I guess I would propose that they matter to whom? Because in many respects, much of what we're going to debate now matters more to us as physicians than it does to the patients that we're dealing with now. Now, those patients may tell us something different 20 years from now, or 20 years from the time that they make the decision. But right now, what patients are interested in is not necessarily the same thing that we as their physicians are interested in. So what are parents and patients, their primary concerns? Well, there was a survey done a number of years ago now looking at what kinds of concerns did most patients with inflammatory bowel disease have. I will admit this is an adult study, not a pediatric trial. survey. And you can see the list of day-to-day symptoms: loss of energy, loss of control, body image, isolation and fear, not reaching full potential, feeling dirty, and there were concerns about the usual potential toxicities of the drugs. Nowhere in there was mucosal healing listed as a concern, although this study was done in 2000, and I'm not sure we'd invented that term yet. The FDA has recognized that how people feel in relationship to their treatments is probably something that's important, and so they've foisted on us these patient-reported outcome measures, which are now an important part of all clinical trials. Basically, they're designed to reflect the patient perspective. You know, how does the treatment make me feel? And the FDA feels that these kinds of questions are really relevant in all clinical trials, need to be assessed in all pivotal trials, and that the biologic effects of the treatments are not adequate by themselves, that we need to focus on how do our treatments make our patients feel, and how does it affect their day-to-day lives. Again, trying to figure out how psychological factors influence health-related quality of life has been a question that's also been reflected in the literature. It turns out that health-related quality of life is affected at least as much by psychological factors as by IBD clinical activity. And there's this approach to the world, which has been called depressive coping, which many patients with IBD manifest, and it seems to be associated with significant psychological distress. It's patients who manifest this depressive coping have worse self-related health status and an increase of somatic complaints. There are data to suggest, for instance, that after we've controlled inflammation in our ulcerative colitis patients, as many 30% of them still have ongoing complaints in a daily way of pain and require additional treatments that may not be anti-inflammatory. We all know that there are a variety of mechanisms by which psychological factors may actually promote more stress, by increasing gut motility and permeability, by promoting more immune reactivity, potentially affecting luminal flora, maybe by what it is that our diets become when we become depressed or become stressed, more maladaptive behaviors such as not sleeping well, potentially smoking in the older kids, and certainly the problem of adhering to medical regimens. So I guess the question that we have to ask, and we started to in the last session, which is, are therapies which have these potential toxicities that people are so afraid of that they don't want to talk to you about, are these really changing the natural history of the disease? And whether you're talking about the thiopurines or the anti-TNFs, you certainly can show that they're corticosteroid sparing. Do they really prevent a change in phenotype from inflammatory disease to either stricturing or fistulizing disease? Well, anti-TNFs probably do it somewhat better than the thiopurines, but they certainly don't prevent that change in phenotype over time. They may delay it. Risk of first surgery, again, probably just delay things. Postoperative recurrence are seen despite these ongoing treatments. Do these therapies improve growth? Well, thiopurines probably not, based on the data that's out there. Anti-TNFs do, but do we still see stunted patients despite our therapies? Yes. And is striving for mucosal healing, does it increase the toxicity risk? And we've already talked about this today in terms of the potential risk for opportunistic infections, for malignancies, and for autoimmunity or immunogenicity. So I'll leave you with that. Again, my feeling for how my debates go. I'm actually not King Kong. I'm the little one in the skirt at the bottom. And you all recognize Bob. Thanks very much.